Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. My guest today is Dr. Yana Aznavour, who's the CEO and founder of a company called Endometrics. She has 10 years of experience in the endometriosis field, combining clinical management, surgical treatment, and molecular research. Dr. Aznavour, welcome to the Tate Chronicles.
Thank you so much for having me. Hi, Jim. Yeah, very excited about this conversation.
I really am also, because any new development, whether it's in workflows or process or technology or diagnostic testing or treatment, I want to know about. And so I know that Endometrics has developed a non-invasive tool for endometriosis. And while it's not commercially available yet, it's coming, and I want to hear more about it. So let me hit you with this first major question. What is the main problem currently in diagnosing and treating endometriosis, and how does Endometrics solve that challenge?
Sure. Endometriosis is one of the most enigmatic condition in gynecological field, unfortunately, and there's a huge unmet need on the diagnostic side specifically. And the diagnostic delay is up to 10 years. And why is that? Because we do not have any specific symptoms and signs of endometriosis that we can identify in the clinical setting and diagnose it straight away. And also, we do not have any frontline, reliable, non-invasive diagnostic test. The only way we can definitively diagnose endometriosis is through surgery. And of course, our patients would love to avoid invasive procedures for diagnostic purposes.
Well, when you say there are relatively few or no early warning symptoms, what makes, is it a standard of care that this is a provider wants to check this in women, or why do they even go down that road of potential diagnosis?
Yeah, so women with endometriosis, most commonly, they experience chronic pelvic pain. It might be cyclic, it might be non-cyclic, and they also experience infertility, pain during sexual intercourse, pain during urination, during bowel movement. So you can tell they're non-specific symptoms. And unfortunately, these women, they undergo at least 7 unnecessary physician appointments and procedures before they receive a diagnosis of endometriosis. And the pain, the menstrual pain specifically, it's been stigmatized. Women are being told that it's part of being a woman. It's completely normal part of their life. And even they heard that pain is in their head, which is unacceptable. It's a reliable symptom that we need to address all the time. Yeah, and that's why the non-invasive test, clinically grade test, is really needed in clinical settings, so we can timely diagnose it and timely refer patients for appropriate treatment.
How does this non-invasive treatment work? What's the process?
Yeah, so we are developing diagnostic tests using the most biologically relevant sample for women, which is menstrual blood. And we created a kit for at-home menstrual blood collection. It includes commercially available menstrual pad, pretty familiar for women. So we're asking currently study participants, but in the future we'll ask patients, women, to collect menstrual blood on second day of menstrual cycle and pour stabilizing solution on a blood spot and send it to the lab. And within a week, we will release the results once the test is commercially available, of course. And this will help, first of all, to decrease the diagnostic delay. Yeah, sorry.
Well, and so it's, I guess, mailed in, right? Or you use FedEx or UPS, or folks have kind of gotten used to this somewhat, whether they're mailing off a cheek swab for DNA analysis or other kinds of, that's kind of within what normally people do now in a lot of ways. Colon cancer is often, is early
like Cologuard. Yeah, exactly.
Well, exactly that kind of stuff. And so when do you expect this will be commercially available?
Yeah, so we just recently kicked off our final prospective clinical trial, pretty comprehensive one, and upon completion of the study, we plan to launch the test. So anticipated date is first quarter next year.
Okay, that's not too far away.
Yeah.
And so does it require a prescription?
Oh, it will require prescription, yeah. And while we're doing that, we would love to keep physician in the loop, to keep clinician in the loop, because endometriosis is a really comprehensive condition. It should be managed with clinician support. We do not want to keep women frustrated with test results.
Sure. What is the actual chemistry, for lack of a better term, in the menstrual blood that allows you to do a diagnosis? And is this a positive diagnosis or percentage-based thing? How does that work?
Yeah, it's actually a really unique biological sample. It includes blood component, which is pretty similar to our venous blood, peripheral blood, but it also includes a lot of unique biomarkers specific to women's health, women's reproductive organs. And how we structured our research, we started with tissue biopsy analysis first. We analyzed endometrial biopsy to get more endometrial cells in the sample and to get to the true biology, fundamental biology of this condition. And then we, let's say, upgraded the test and improved the experience of our participants and patients in the future by working with menstrual blood. And we comprehensively validated and demonstrated that our biomarker gene expression signature is stable in menstrual blood when collected at home and sent to the lab. And we also demonstrated that there is no variability in this biomarker expression across different days of menstruation phase and different menstrual cycles, which is also crucial for diagnostic tests.
Sure. And so how these biomarkers examined? Is it under a microscope or is it some reagent work? Yeah.
It's a gene expression signature, so we are doing RT-PCR to analyze it.
Yeah. And accuracy of the test.
From our studies, and we conducted series of retrospective studies so far, the sensitivity is 92.3%, specificity 100, AUC 0.98, which means that this nearly perfectly differentiates samples of women with endometriosis from those without.
Did you have to work through any issues in how the sample is transported, being kept refrigerated or anything like that at all?
We tested it rigorously. We simulated numerous shipping conditions, storage conditions, humidity, temperature, you name it. And we spent almost a year just beta testing this workflow. And right now, this sample shipment do not require any temperature conditions, any dry ice, nothing. Women need to pour stabilizing solution provided in the kit on the blood spot, and then send it just in a biohazard bag in the kit with prepaid shipping label that we provide. Currently only available for study participants, as you mentioned. It's not commercially available, but yes, it is how we anticipate the workflow will look like.
And is this when you launch? Well, right now, as you're doing the final research, and then when you go live, do all the samples get sent to one central lab, or?
Yes. Yeah, correct. Yeah, we're starting with one CLIA certified laboratory. Yeah, one central lab.
Exactly. For our listeners, especially men who don't have a lot of experience in this area, can you just give us a little background of what the disorder is, and what causes it, and does it run in families? And a little background.
Of course. Yeah, I love to frame that this way. If you know 10 women, if you have 10 women in your network, you definitely know at least one with endometriosis. And unfortunately, most commonly, they're suffering in silence and they're still undiagnosed, which is ridiculous because, hundreds of millions of women suffer from endometriosis worldwide, and we need reliable tests, reliable diagnosis. So what this condition is about, it's the condition when we see endometrial-like tissue outside of their normal location, which is uterus. So you basically can see lesions outside of the uterus that should not be there. And we, unfortunately, even as OBGYNs, we cannot explain all cases of endometriosis. There are tons of theories, ethologic, pathogenetic theories, but they cannot explain all cases of endometriosis. We still need more fundamental research to be conducted to know this condition better.
And this testing, once it becomes widely available, will it just be ordered typically based upon symptoms or just general screening? How do you think that's going to work out?
I don't know. It's a diagnostic test. And as you know, it really differs dramatically from screening options. And we're not developing screening option for now. So indication for use is women having pelvic pain and infertility.
What's the status as far as insurance coverage?
Plan to get insurance coverage for that to make it highly affordable and accessible. We just recently got into this amazing health equity and business program collaborated with Blue Cross Blue Shield of Massachusetts as part of their HEBA accelerator. And we are working towards understanding how to get that covered. But we definitely need to secure new PLA or CPT code for coverage to make it affordable. You might know that only a third of women of childbearing age in the US have insurance coverage. So millions of women need affordable options to get this timely testing.
Yeah, and so obviously you're talking about early detection and based on menstrual blood. So menstrual blood is available only in certain times in a woman's life.
Yeah.
And so is that also kind of a close overlap with the period when they might be coming to terms with this or when it might occur in endometriosis?
Do you mean is there a correlation between menstruation and endometriosis?
Well, I mean, as far as in the timing. So it's a woman in their 70s is probably not going to be able to do your test. But does it? Go ahead.
Yeah. We need menstruating individuals in order to test it.
Exactly. And so does endometriosis usually occur early in a woman's life cycle? I mean, it's something that's going to occur. It's going to be in their 20s or 30s or 40s.
Yeah, most commonly we see this among patients of childbearing age.
Sure.
And 60% of patients, according to ACOG statistics, experience first symptoms during adolescence period, but they are being misdiagnosed a few times and treated for conditions they do not have before even being referred to OBGYN. But I need to acknowledge that we do have cases of endometriosis at postmenopausal period. And, but our test is focused on menstrual blood diagnostics, so we cannot test these cases for now.
I kind of wonder in the future if menstrual blood can be used for diagnosis of other conditions.
It should be. Yeah, and we're working on that. We are not disclosing our full pipeline yet, but we do have other indications, other product at the proof of concept stage. Yeah, and ideally, this is how I envision, is that menstrual blood sample that is being currently just utilized by women is being used for multiple diagnostic indications. And it's simple for women to just collect this menstrual blood in a private setting, in a comfortable setting of their home, and send it for analysis.
Let me mention to our audience, if you're just joining this episode, I'm Jim Tate. On this episode of the Tate Chronicles, speaking with none other than Dr. Yana Aznavour about Endometrics and a non-invasive diagnostic test that she's developed over a number of years. Right now, if there is a suspicion because of symptoms like chronic pain or menstrual pain, and they go to their provider, are there several steps that are taken before an invasive procedure is done?
Yeah, for sure.
What's the state now? What happens now?
Yeah, so surgery will never be the first call, of course. You would love to exclude those conditions that you can easily exclude or try to identify those conditions that you could easily treat. So that's why women with endometriosis, like 74% of our patients with endometriosis are being repeatedly misdiagnosed before they receive endometriosis diagnosis. And they're being constantly referred to GI specialists, neurologists, urologists, anyone who can deal with pelvic pain, but unfortunately not OBGYN first. And we would love to change this paradigm.
So if I guess there's a couple of ways this process may present once you go live. A woman may go to their provider, whether it's internist or OBGYN or whatever, describe some symptoms, and the provider may say, well, let's do this.
Mm-hmm.
And so is the kit, for lack of a better word, mailed directly to the patient's home?
Mm-hmm.
Okay.
Yes, yeah, like Cologuard. Yeah.
Okay.
Physician identifies eligible patients who should be tested, and
Yes.
we will take Cologuard's model, and send it directly home.
It sounds like there's a potential for the entire workflow around early diagnosis and treatment could be disrupted by this technology.
I hope
and
so. I think
yeah,
it should be. Mm-hmm.
and so the providers, obviously, they're going to need to add this to their current practice and workflow. So, how's the training or the understanding of the education? How are you going to do that?
Yeah, we are working not only with potential patients, but also with clinicians for sure, because we need to spread the word about this innovation once it's finalized and commercialized. We received an award from American Association of Gynecological Laparoscopists, which is the largest society in complex benign gynecological field. And they're basically endometriosis surgeons, endometriosis experts. So we got this clinical recognition. And we're also constantly talking to primary care nurse practitioners, fertility specialists, OBGYNs, GI specialists, because we need to think about this misdiagnosis. And IBS is one of the top misdiagnoses that women with endometriosis receive. So we would love to see, we will definitely, present at conferences, at scientific meetings, at exhibitions, at large professional societies meetings, and we will spread the word about this innovation once it's finalized and ready for launch.
Let me take you back to the beginning. How did this idea pop into your mind? Did it happen over a period of time, or did you suddenly thought, well, there's an option here? How did it happen?
It's an interesting story. I'm a surgeon by training, so I was treating these patients in the OR. And of course, we treated other complex benign conditions, but the majority of patients, they had endometriosis, and they've been referred from other surgeons, other OBGYNs from other cities, because previous surgery was not successful enough and symptoms recur. So I've been thinking about something more non-invasive and more reliable at the early stages of their life, because they suffer for years. These women suffer for years in desperate pain and debilitating pelvic pain. And also with infertility, they receive this diagnosis, unexplained infertility, which is in reality is unexplored. You need to dig in, you need to identify these underlying conditions. But how you would do that if you did not have non-invasive tests? And, I've been fully clinician, I have clinical mind, and I started working as clinical advisor for several companies in femtech field. And I realized that they lack this clinical insight. They do not talk to physicians first before they innovate. And this gap between innovation and the clinical reality is really what pushed me to start the company. And I knew that science was there because I structured this really strictly, and I care about science a lot. I always say that science first, and then you innovate, and then you commercialize test. And that's why, I decided to build a product around the good science that we had already.
And I imagine there were a few years just developing prototypes.
Oh, yeah.
Collection and shipping and arranging all those kind of things. So this is not just something that's been, you formed the company. When was the company?
Sure.
When was your company? When was?
In 2022, and we've been in research mode for 7 years before incorporation. Wow. So exactly. It takes a while. Yeah,
exactly.
And I think and as a note, I think this field it's important to not rush things in women's health field, especially diagnostics. It's really important to do rigorous science, rigorous validation first, be 100% sure that it works before you incorporate something into clinical workflow. Because women's healthcare has so many gaps, have so many unmet needs. If you would love to innovate, if you would love to actually help patients and clinicians to become a win-win situation for the current women's healthcare, you need to be 100% sure that your solution works. So that's why we've been quite, rigorous on science part before we even started thinking about the business part.
Tell me a little bit about the process if a woman is not diagnosed and is never treated. What's the effect on your life? Yeah.
How currently it looks like, so patients suffer for years from pelvic pain. And even when they receive this clinical suspicion of endometriosis, they've been treated with empiric hormonal treatment. And most commonly, as I said, patients start experiencing symptoms in adolescent period. So they basically start getting this hormonal treatment in adolescent period. And you need to think about side effects. You need to think about adverse effects of long-term hormonal treatment, the effect that it can have on your oocyte quality, on your reproductive potential. You need to think about ahead of time. And it's also important to note this anxiety that our patients experience when they do not have this clear diagnosis, clear answer to their symptoms. When it's just, let's try hormonal treatment and see if that works. I think you have endometriosis. That's not an ideal answer from physician that our patients would love to hear. We surveyed more than 120 patients, and almost all of them mentioned that they experienced pre-hormonal treatment anxiety, pre-operative anxiety, because physician is not quite sure there is endometriosis. And we would love to become this objective clinical decision support tool for physicians as well, and help patients navigate their journey.
I believe you said earlier this may affect up to 10% of women. I think you said 1 out of 10.
And if left untreated, of course, the disease can progress. It can lead to infertility, and the quality of life of our patients with endometriosis is just out of this world. Yeah, it's not it's not cancer, although it has a lot of biological features similar to cancer, but we call it benign. Although it's not benign, it's really life-changing experience. It affects their normal life, daily routine. They skip school, they miss work, they miss daily activities. It ruins relationships because it's debilitating pain that they could not even perfectly describe where it hurts. It hurts everywhere, basically. It's truly enigmatic, truly comprehensive condition, and we need to acknowledge that it's there. We have the substrate of this pain. We just don't know how to diagnose it non-invasively right now.
There is, I guess, since the passage of the Affordable Care Act, there was a minimum requirements for insurance companies to cover certain wellness-related things, colonoscopy, mammograms, things like that. Do you anticipate that this will be covered under kind of course, under the wellness things? Those are like widespread screening. Yours comes into place once there's some symptomatic indications, it sounds like.
Yeah, of course, it's not screening. It's not wellness for sure. We're not providing just healthcare insights. We are through diagnostic tests, but still we are working towards getting it reimbursed.
This whole concept
so it can be more affordable.
Sure. This whole concept of patients being more responsible for their testing. 10 years ago, we would not consider a patient doing a home injection. And now, I don't know how many million people are injecting GLP-1 medications every month. And so to kind of bring it forward to the diagnostic side, and certainly with Cologuard, there seems to be more and more comfort and cultural acceptance for being responsible for your own diagnostic procedures, more or less, that people can be trusted to do it correctly and get a good sample and package it correctly and send things in.
People should be trusted. Women know their bodies. And I love this trend that women are starting to be their own advocates for their health, getting second opinion if first one did not address all questions and concerns. I love this trend, and I love that our patients are super knowledgeable. They read a lot before appointment. They ask great questions. And I think we should definitely trust them with the diagnostic workflow for sure.
One of the things that I personally find exciting about the development work that you've done is that it speeds up diagnosis.
Yeah.
I mean, in a non-invasive way. That's
our main goal.
Disruptive.
Yeah.
That's disruptive.
I agree. Yeah.
Go ahead. No, please go ahead.
Yeah. We also phrase that we would love to decouple diagnostic procedure and surgical procedure. Of course, surgery will remain the treatment option, but we would love to have non-invasive diagnostic option. And yeah, the primary goal is to decrease this diagnostic delay, because no disease should be diagnosed within 8 years. That's ridiculous to have such an enormous diagnostic delay and just keep women suffering in silence.
Before we say goodbye, please
and waiting for an answer.
Yeah, let our audience know how they can find out more. What's the website?
Yeah, we have a website, but there's scarce information because we are still conducting our prospective trial. But upon completion, we will let you know once it's ready for official launch and will be available for use. Yeah,
sure. And I think but there is information, at least about the website, which is at Endometrics, right?
Yes, endometrics.com or .us. You can use any domain. And yeah, we are always open to conversations with patients, advocates, patient organizations, clinicians, investors, of course, and potential partners. Yeah, always open to this discussion.
Going there is a good way to maintain contact.
That's for sure. Yeah, and we need to hear patients' voices. We need to work based on their feedback. That's what we've been doing this years, and this is really critical.
To our audience, thanks for joining me on this episode of the Tate Chronicles. I, of course, offer a special salute to my guest today, Dr. Yana Aznavour, the CEO and founder of Endometrics. Thanks for coming aboard today.
Thank you so much, Tim. Thank you.
You can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.